Here Dr. Alpesh Maru. Today we are going to discuss some clinical pathology topics like stool examination and sputum examination. In fact, both the topics are very useful in microbiology, in theory as well as in practical. But as far as pathology is concerned, particularly from the stool examination, occult blood examination in the stool. This is the frequently asked viva question as well as theory question. And as far as sputum is concerned, usually grading of AFB stain and something like sputum cytology. These are the newer questions they are going to ask in pathology. But in fact, these two topics are very useful in your clinical practice. When you are practicing, patients usually come to you with complaint like pain in the abdomen, nausea, vomiting, bloating sensation, indigestion, malabsorption syndromes like symptoms, in particularly in children having parasites. So in that cases, you are going to do or advise stool examination. And few things regarding sputum examination is it is very useful for early evaluation or screening for carcinoma lung. That is by sputum cytology. And one more thing, that is in bronchial asthma, you will find some characteristic crystals and appearance in the sputum. So this is very important topic. And as far as tuberculosis is concerned, a Zn stain and immunofluorescence stain on the sputum sample, that is frequently practiced nowadays, and that is the criteria under RNTCP program. That was the criteria. So these are about basic introduction of stool examination and sputum examination. Let's start with stool examination first. So composition of stool, the stool is made up of indigestible materials, particularly cellulose of last 4 days, bile pigment, salts, mucus, sometimes leukocytes, shredded epithelial cells, and some bacteria and inorganic salts, particularly calcium and phosphate. So this is how stool composed of. Now indications, particularly a patient complain of pain in the abdomen, abdominal discomfort, having diarrhea, anemia. So that is in spite of giving hematinics, HB is not going to increase. So in that case, you look after blood in the stool. And sometimes a child who is not going well grow well, and sometimes red color or some abnormal color stool. These are the certain indications of stool examination. Now again we can say it is done to identify disease of GIT, liver, pancreas. Some symptoms like as we already discussed, like diarrhea, bloody diarrhea, in fact, continuous gases, nausea, vomiting, loss of appetite, bloating, abdominal pain, cramp, fevers. Sometimes look for intestinal parasites. Some other than parasites and routine symptoms, there are some fungal infections, viruses you can look after. So these are the various indications. And last but not the least, that is malabsorption syndrome. So this is why we are going to examine stool. Now first thing is collection. How to collect the stool? A universal precaution should be there, and it should be collected in a dry clean container. I'll show the photograph in the next slide. And it should be uncontaminated with urine or other body fluids, particularly a female having menstrual blood. And it should be delivered immediately after collection. Now for ova and parasite, some preparation you should do, that you should not refrigerate the same specimen when you go for ova and parasite detection. That is most important thing. Second thing, so if you collect the stool in 10% formalin or some other fixatives, then temperature is not that much critical. And it is recommended to go for more than two or sometimes three random stool specimens to check for parasite. Now these are the universal container for this tool. These are for stool swab even. So this is how you can collect a specimen. Now something regarding rectal swab. So when stool is not available, stool sample is not available particularly, then you have to prepare this sterile swab dipped into this buffalo glycerol and introduced into the rectum, and make sure that it should not contaminate perianal skin or some other surrounding structure. Now, after collecting the sample, the swab should be inserted into this sterile glass container having preservative medium like Claribel medium or VR fluid. Now, these are the rectal swab, and this is how you can introduce swab into the rectum. Now, stool examination proper. It should be divided into macroscopy, that is gross examination, chemical examination, and microscopic examination. Now, all the three component has their own significance, but physical examination, we can say gross or macroscopic examination, has its own significance, because by seeing color, odor, by gross blood or even gross parasites, half of the work we have already done through just gross examination. As far as chemical examination is concerned, a very important chemical test, that is test for occult blood. This one. Now, occult blood, this is a very important theory question in pathology. And now, microscopically, go for RBC, go for pus, you check for bacteria, fat globules, and very important thing is this parasite. So, this is how stool examination is divided. Now, we'll see all the things one by one. First of all, physical examination, gross examination. Normally, consistency of stool is well formed, and you all know if it is very hard, a patient having constipation, semi-formed, particularly in parasitic infestation, soft stool, again parasites, loose diarrhea, loose watery. That is particularly in cholera, that is bacterial infection, and once it is flattened or ribbon-like consistency, it suggests a particular obstruction in the bowel. So this is the thing you should know about consistency of stool. Next, rice watery, it is again cholera. Steatorrhea, that is the important terminology when you find plenty of mucus and blood, so it is again foul smelling stool. And dysentery, having blood and mucus, sorry, steatorrhea, that is fat in the stool, and dysentery, that is mucus and blood in the stool. Now color. Usually it is brown color due to urobilin and stercobilin, that is the metabolites of bilirubin metabolism, that impacts typical brown color. Now abnormal color, particularly whenever there is upper GI bleeding, particularly in peptic ulcer, stomach carcinoma, esophageal varicose bleeding. So in that case, it is black color stool, and very important treatment part, that is iron medication. In case of anemia, stool become black color. And whenever there is lower GI bleeding, particularly in piles or anal fissure bleeding, it is bright red color. So this is how by color of the stool you can differentiate whether it is upper GI bleeding or lower GI bleeding. Third one, that is clay color stool, that is because of obstructive jaundice. And silver color stool, particularly in case of carcinoma of ampulla of Vater. So these are the various abnormal colors. One more, red brown color, that is due to certain drugs like rifampicin and broad spectrum antibiotics like tetracyclines. So red stool color may be seen if there are some indigested beads or tomatoes. So you should always ask for some food history before come to any conclusion. Now odor. Usually it is offensive and depends on the pH. And why it is offensive? Because these are the some gases produced by bacterial metabolism that gives typical offensive odor. But sometimes it is odorless, and that usually seen if there is no fecal matter as in bacterial infection. Sometimes it may produce. Sometimes it is very offensive, as in case of constipation, and sometimes due to some excessive gases. Next, that is mucus. Usually undetectable amount is present. and abnormally large number of mucus present. So you can see these are the grading +1 +2 +3. Such kind of large amount of mucus is present in the form of white patches, and there are certain causes are there, we will see later on, but this is how you can check for mucus in the stool. It is very sticky in fact. Now fat. Normally fat in the stool takes account 20% of the total solids, and usually increase in the fat, that is known as steatorrhea, and that is seen in malabsorption syndrome, particularly these non-tropical sprue, Whipple's disease, Crohn's disease, cystic fibrosis, some pancreatic disorders. These are the conditions where you will find fat globules in the stool. Now, how to detect this fecal fat grossly? So there are four methods: titrimetric method, gravimetric method, acid stereotypic method, and mid-infrared spectroscopy. You should at least know these different name of methods. How to detect fecal fat? In our practice, usually we can detect fat globules on the microscopically on saline preparation, and that is good enough for considering abnormal amount of fat. Now gross blood, normally it is devoid of blood, and you cannot see it by naked eye, very frank, but sometimes abnormal fresh blood in case of lower GI bleeding, so you can definitely grossly find some blood in the stool, and it is due to piles, anal fissures, and some parasites like schistosomia, that is known as bilharziasis. So these are the conditions where you find gross blood in the stool. Now naked eye parasites, very important thing. Usually it is there is no parasites in the stool, and some parasites may be found, particularly Ascaria lumbricoides, that is roundworm, Enterobius vermicularis, that is pinworm, and Tinea saginata. So these are the various parasites you can see by naked eye. So you can see this is the roundworm, adult roundworm, Ascariasis lumbricoides in the gross examination of the stool. This is adult tapeworm. These are again adult worm. You can see over here, over here. So these are the various photographs of worms in the stool grossly. Now chemical examination. That is again very important. These are the certain parameters. So water up to 75%, pH in between 6.5 to 7.5, occult blood should be negative. This is very important. Urobilinogen, normally it is up to 500 to 300 microgram in 24 hours. And these are the various levels of porphyrinogen, nitrogens, bile. Usually it is negative in adults, chloride, potassium, and fatty acid. So these are the various normal values in chemical examination. Start with pH. Usually it is variable, but high alkaline pH always indicate high protein diet physiologically, and pathologically it is due to poor fat absorption. At the contrary, high acidic stool, but obviously physiologically when you have high carbohydrate diet, and pathology is concerned, it is due to poor absorption of sugar, as in lactose intolerance. So this is how pH become abnormal. Now very important theory short note in pathology, that is occult blood in stool. Occult blood means hidden blood, so you cannot grossly detect the blood. For detection of blood in the stool, you should go for certain chemical procedure or chemical reaction. That's why it is known as occult blood or hidden blood in the stool. And it is very important because sometimes grossly you cannot find blood in the stool, but it is going to shed out in the stool continuously, and patient's hemoglobin doesn't improve. So how we have to detect it? With the help of some reagent, that is particularly useful, benzidine, commercially available, orthotoluidine. Now these reagents have peculiar characteristic, like once there is blood in the stool, the heme component, this one, these heme compounds usually they catalyze certain substance like benzidine, orthotoluidine in the presence of H2O2. So what we are going to do, mix benzidine with glacial acetic acid, and with presence of H2O2, we are going to mix these three solution into the stool sample. If there is blood, or we can say heme in the stool, now they are going to catalyze benzidine, in the presence of H2O2, and they will produce some bluish color, the impact blue color, and that is suggestive of positive occult blood test. So reagents used are benzidine, orthotoluidine, guaic test, immunochemical testing, and commercial available strip. Again, as we discussed earlier, prepare the emulsion of feces with the water in the test tube. Mix benzidine with glacial acetic acid and H2O2, that is hydrogen peroxide. Now add 5 ml of boiled fecal emulsion to this reagent and go for or wait for deep green color to develop. If this green color develop, it is suggest occult blood is present in the stool. Instead of benzene, you can use orthotoluidine. The rest of the procedure remain same, and again the color is bluish green. And this is the commercially available hemo-occult kit. Usually we use this kit in the laboratory for detection of occult blood. Now last portion of this tool examination, that is microscopic examination. You go for saline preparation, iodine preparation, and concentration procedure. Usually we are dealing with these two, usually saline and iodine. Iodine, that is for cyst detection, particularly to stain the nuclei of the parasites, and saline, that is for trophozoites and other abnormalities. In saline preparation, you just need to mix saline with this tool, and here you going for iodine preparation, that is Lugal's iodine. We see one by one. Now these are the saline and iodine preparation. Now saline wet mount preparation, how to do? First, place a drop of saline on the slide. Now take a small amount of stool with the wooden stick. This is the stool container. Now with this stick, you put some sort of stool sample on the slide. Now we going to mix it. Now place a cover slip and make sure there is no air bubble. This is very important. Now there is one mistake commonly done, that is too much stool, and that should be avoided. So it should be in proper proportion. Now iodine preparation, it is again very important. Place a drop of Lugal's iodine on the slide, mix it with the fecal material, and place a cover. And again, as we told earlier, iodine stands for cyst, that is for nuclear structure. So this is about saline method and iodine method. Concentration technique, when there is a small number of parasites and you cannot see grossly by means with the help of saline or iodine, and you are strongly suspect there is parasitic infestation is there, then go for either sedimentation technique or flotation technique. Both have their own merits and demerits. Particularly in sedimentation technique, they are going to settle down eggs and cyst of the parasites in the bottom, while in flotation techniques they are going to float over, is it has very specific gravity is less than saturated saline, so they are going to float on the surface, that is over the of the parasite. So both have some drawbacks. In disadvantage in sedimentation technique, that parasites are masked due to excessive fecal material, and a disadvantage of flotation techniques, all ovas or cysts do not float. So both have their own merits and demerits. And sedimentation technique again divide into simple sedimentation technique, and with the help of ether it is known as formal ether sedimentation, again used for heavy eggs, particularly roundworm, operculated eggs in case of trematoids, and some larva migrant syndromes in case of stercoralis, and some cyst. So that's all about three different technique: iodine preparation, saline preparation, and concentration technique. Now by after completing any of these three method, what you are going to see under microscope? Either go for pus cell, you have to observe about for RBCs, gross vegetables, starch, fat globule, other undigestible materials like cellulose, and most important thing, that is parasites. So first of all, pus cells. Pus cells are nothing but they are neutrophils or WBCs. So you can see such kind of pus cells under high power microscope, and if you are going to count it, if it is more than 100, stool culture is recommended because you have strong bacterial infection, so you are going to go for stool culture. Now RBCs normally they are 0 to 3, very less under a high power of field, and if it is more than like if 10 to 12, 30 to 40 and so on, then you have to go for, or you have to think about some lower GI or upper GI bleeding. These are the various crystals, some undigestible materials, and these are the WBCs. So these are the various things you can see in the stool examinations. Such kind of refractile structure you will find in the stool, that is RBC. Now epithelial cells, these are the epithelial cells. Normally they are very few or absent, and increased epithelial cells suggest some irritation in the GI tract. Starch normally found +1 grade, and if it is there is some indigestion or malabsorption, it is more than +2 +3. Now fat globules normally found is a grade 1 under high power field, and increased fat, and in case of pancreatitis, some malabsorption syndrome like celiac sprue, you will find such kind of fat globules. You will find such globules, like these are the fat globules. Now abnormal constitutes like hematoidin crystals, as in case of GI hemorrhage, and particularly charcot leaden crystal. This is very important. A typical crystal seen in some parasitic infestation, particularly amoebiasis and in ulcerative colitis. Now these are the parasites. These are the various cysts of ant amoeba histolytica, tropozoites forms, vegetative forms, we can say. Now this is cyst form, ant amoeba histolytica. So we going to see some of the cyst tropozoites and ova of tropozole parasites as well as helminthic parasites. Now these are the cyst and tropozoid of ant amoeba coli. These are the pear-shaped stellate exhalates of Giardia lamblia, that is responsible for giardiasis. Now this is the iodine preparation of Giardia lamblia. Typical cyst structure of Giardia. Isospora belli. You can see a typical egg of Isospora belli. Now Belnitidium coli, B coli, that is bean shaped macronucleus and globular micronucleus. Cyclospora. So these are the things usually you have to examine all these things in your microbiology practical exam. So we are just taking all the photographs one by one without discussing it in detail, because the all things will be discussed in your parasitology separately in your microbiology. Now Cyclosporidium parvum, Ascariasis, these are the unfertilized egg, and this is fertilized egg. Again the same thing, roundworm, eggs, hookworm egg. Now this is a bipolar, you can say barrel shaped operculated egg, that is Trichuris trichuria, and this operculum is situated in the both dipole, that is bipolar. Trichuris trichuria, particularly seen in the children. E. vermicularis, that is panoconvex shape. This is the typical egg of E. vermicularis. Entropius vermicularis, that is even again on the UV microscopic light. D. latum, that is fish tape form. You can see these unsegmented yolk granules in the egg. Now H. nana, Hymnolepis nana, again the two distinct membrane, outer is thin and colorless, and inner embryophore having three pairs of hooklet. You can see these are the three pairs of hooklet over here. So this is the H. nana egg. Tinea saginata, very important parasites, and this is the typical cells of this outer membrane of this egg, and this is inner embryo 4. So These are the various eggs of parasites that is present in this stool, and that's all about all microscopic examination of this stool. Now some confusing structures that mimics parasite but actually they are not parasites. We should always think about such things. Like here you can see RBCs and WBCs can be mistaken as parasitic cysts. Such kind of things may be mistaken as cysts, but they are not cysts. Second one, RBCs may appear to have a central body and rim of cytoplasm. Looks like blastocystis hominis. This structure is looks like cyst of some parasites, but it is not. It is nothing but RBCs. Now you can see here a triconstant macrophages looks like entamoeba histolytica, or we can say amoeba, but it is not like that. Fat globules may appear some parasitic cyst, so always go for add emulsifying agent to eliminate this kind of potential confusion. Now here it is mistaken as strongyloid stercoralis. This is not parasite, but this is hair. So these are the confusing things you should keep in your mind when you go for microscopic examination of this tool. So that's all about stool examinations. Gross, chemical, focal blood is very important, chemical examination, and microscopic examination, all basic structure like pus, RBCs, epithelial cells. But very important thing is certain eggs, cyst and trophozoites of parasites. So that's all about stool examination, very important clinical aspect. And now last and very small topic, that is sputum examination. It is again divided into physical examination, chemical examination, microscopy divided into again special method in the form of fluorescent microscopy and exfoliative cytology. In stool and as well as in sputum, sample collection is very important. So patient is instructed to rinse the mouth with water to avoid contamination by food residues. So we have to collect expectorant like sputum rather than saliva. So you have to instruct patient to cough out clearly and collect sputum directly into the sterile wide mouth tightly packed screw cap container. Right. For tuberculosis, early morning specimen is very important, and once you go for some empyema pyogenic abscess like things, it is advisable to collect sample in the sterile petri dish, and it is ensured that no antibiotics or chemotherapeutic agents given before culture examination, and specimen should be destroyed once you go for once you complete your examination. It is destroyed by heat or chemical disinfector because this is potentially a hazardous biomedical waste. Now start with physical examinations. Normally 2 to 4 ml of quantity in 24-hour collection it is seen. Of large amount of we can say more than 100 ml per day. In 24 hours it is around 100 ml up to 100 ml. It is more than 100 ml per day. It is seen in bronchiectasis, lung abscess, pulmonary edema and pulmonary hemorrhage. And if it is more than 500 ml per day with typical anchovy sauce color like sputum, it is seen in amoebiasis. So these are the certain parameters regarding quantity. Now color, usually it is clear and colorless. Yellow in case of some infections like pusses. In greenish, particularly pseudomonas like bacterial infection. Rust red and bright red. Two reds are there. Rust red is particularly seen in pneumococcal pneumonia and pulmonary gangrene. It is due to decomposition of hemoglobin, and recent hemorrhage in the form of bright red color in the sputum, and it is due to rupture of the vessels, pulmonary tuberculosis and pulmonary infarction. And sometimes black color sputum is particularly seen in anthracotic tissues or dust, and that is the inhaled dust produce black color sputum. Now third parameter, that is consistency. Usually it is colorless, watery and opalescent. In case of pulmonary edema, sputum is serous, mucoid. That is very important in case of lobar pneumonia, whooping cough, bronchitis, asthma. You will find a very sticky mucoid consistency of pus, sputum. Purulent, particularly in lung abscess, empyema. In case of even bronchiectasis, it is purulent, mucopurulent mix. That is in case of bronchomoniasis. Sometimes it is totally mucopurulent. Bloody in case of tuberculosis, congestive cardiac failure, mitral stenosis, pneumonia, acute bronchomoniasis, some malignant tumors of the lung, bronchi. So in that case, it is bloody. And encovisous sputum that is in seen in amoebiasis. So these are the very important physical examination parameters. By just seeing color, volume, and consistency, you may reach up to certain diagnosis, or you may rule out some diagnosis. Now odor, usually it is devoid of any odor, but foul smelling in case of lung abscess, sweaty in case of pulmonary TB with cavity formation and bronchiectasis. Now here there is formation of 2 to 3 layers in the test tube. You may observe these things, and it is due to this bronchiectasis, lung abscess. And how? Top layer made up of frothy mucus, middle there is opaque water material, and the bottom that is known as sediment, it is made up of pus, tissues, or bacteria. So there are the three layers formed in the test tube when you collect this sputum of a patient of bronchiectasis or lung abscess. Now, examination of sputum in petrides. When you see some cheesy mass in the sputum, and it always go towards highly necrotizing tissue, as in case of tuberculosis. Dietrich plug, very characteristic structure found in bronchial asthma, sometimes in bronchitis as well as bronchiectasis. Bronchioliths, that is the calcified stagnant content, and that is seen in calcified tuberculosis. And lastly, sulfur granules, a characteristic of actinomycosis. Whenever it is present, you will find sulfur granules in the sputum. So it is advisable to go for sputum examination in the petrides. Otherwise, you will miss such kind of small structure, and that is very diagnostic. Now, after completion of physical examination, we are going to see under microscope, that is microscopic examination. In stool we have saline preparation, iodine preparation. Here only wet preparation. You just put a cover slip on the collected sputum specimen. Usually very few pus cells, as many as in case of inflammation. RBC is usually present, but in very low quantity. High number of RBCs in malignant tumors. Heart failure cells, that is nothing but a congestion in the lung, that is known as CVC, chronic venous congestion. Heart failure are nothing but macrophages. Carbon laden cells, that is in case of occupational lung disorders, particularly anthracosis. Kurtzman spirals, that is very important thing. Twisted mucoid strand, they are arranged spirally, enclose these epithelial cells. A very diagnostic material in case of bronchial asthma. Crystals, very important, charcoal leaden crystal. It is colorless, pointed, needle-like hexagonal structure is seen in case of bronchial asthma. Sometimes you will find a gross cholesterol crystals in case of empyema, chronic tuberculosis, and some tyrosine-like crystals in case of emphysema, rupture of emphysema in fact. And elastic fiber-like structure also seen. They are highly refractile fibers and usually seen in the destructive lesion of the lung like TB and carcinoma. So these are the miscellaneous structure in the wet preparation. Now you can see these are the charcoal radon crystal, a typical needle-like crystal. And here Kurtzman spiral, you will find such kind of spiral-like arrangement, that is nothing but mucoid strands. So these two are pathognomonic of bronchial asthma, charcoal laden crystals and Kurtzman spirals. Now parasites. Amoeba histolytica. Sometimes whenever there is a rupture of amoebic liver abscess into the lung, you will find such kind of things. Hydrated cyst of the lung. Sometimes you will find these scoliosis and P. westermanni, that is the lung fluke. So these are the gross parasites you will find, microscopically find parasites in the sputum. Now as far as fungus is concerned, very important is Candida and Aspergillosis, and one more, that is mucormycosis. It is usually seen in immunocompromised patients, particularly HIV. Now these are the typical Candida, budding of this Candida fungal infection. It is very identical. Now you have to you are going to confuse in between aspergillus and mucor, but it is very easy. Aspergillus always septate hyphae, and mucor it is aseptate hyphae. You can see such kind of septate hyphae, and here mucor it is aseptate hyphae. So these are the mucormycosis. These are the typical septa in case of aspergillosis, and these are the spores of candidiasis. So these are the various fungal infections that are present in the stool. That's all about wet preparation. Now we are going to stain the specimen by either Leishman stain or Giemsa stain. Using a platinum loop, you made a thin smear on the glass slide, and it is not to be fixed. Usually it is treated like blood smears, and if there is acute infection, sputum shows large number of polymorphs. In chronic infection, they are usually monocytes, lymphocytes, and lipoid pneumonia. You will find macrophage with vacuolated cytoplasm, and treatment a large number of eosinophils is case of tropical eosinophilia and bronchial asthma. So this is how this 10 preparation, particularly Leishman and Giemsa, getting useful. Now another preparation that is gram stain, but here there is mixture of organisms are seen, so it is not that much diagnostic. But Zn stain, that is the gold standard, I can say, in our setup. Zn stain is useful for AB. It is very easy to identify these things on this slide, because these are the tubercle bacilli, pink color, slender, beaded bacilli, right, on the background of bluish. So this is the blue background, pink bacilli, characteristic of Zn stain. But here it should be, it is large number like 50,000 per cubic mm, and if it is less than this number of bacilli, it is not going to detect. So sometimes negative report doesn't exclude pulmonary TB. So we are going to do at least 3 different sputum smear examination for Zn stain, and once all these 3 getting negative, then we are going to give negative sputum report. Now grading is very important. Once you go for 100 oil immersion field and you will not find any bacilli, then it is considered as negative, or we can say grade 0. When you find 1 to 9 bacilli in 100 oil immersion field, it is scanty. When you find 10 to 99 acid fast bacilli in 100 oil immersion field, it is plus 1. When you find 1 to 10 bacilli per field, now it is not per 100 but it is per field, then it is plus 2. And once you find more than 10 bacilli per field, it is plus 3. So this is how you are going to grade Mycobacterium tuberculosis on Zn stain. Now to overcome some limitations of Zn stain, like once you have a low acid fast bacilli load, then it is not useful usually detect low bacilli load, and so in that case you have to go for some more sensitive test, that is fluorescent, we can say immunofluorescent testing. So bacilli in this sputum stain with this fluorescent dye like oramine or rhodamine, and once you go for UV light, so irradiate with UV light and see under fluorescent microscope, it appear as brilliant yellow rods on the black background. Here in Zn stain you will find blue color background, pink bacilli. Here in immunofluorescent you will find black color background and yellow rod, that is yellow bacilli. So usually this bacilli uptake this fluorescent dye, and once you pass this UV light, they become irradiated and producing typical yellow color structure. It is very simple, very efficient, and very far better than Zn stain as far as sensitivity is concerned, but it requires some trained hands and it is little bit costlier as compared to Zn. So you can see these are the yellowish slender bacilli on the black background, like, and this is Zn stain, bluish background and pink bacilli. So this is how you go for sputum examination with saline preparation, that is wet preparation, stain preparation, that is Giemsa, and then Zn stain, and this is special preparation is in case of immunofluorescence. Now few things regarding concentration method. When once you have a very low number of sputum samples, very low sample, otherwise sample is mixed with some mucus or contaminated organisms, so in that case you will not able to find out proper bacilli. So once you strongly suspect tuberculosis, but you will not find some bacilli. So you have to destroy some unnecessary materials like mucous cells, these contaminated organisms by means of chemical digestion, so that live bacilli are preserved and rest of the things get destroyed. So with this principle, we are going to perform this concentration method. So here you have to mix sputum with equal amount 4% NaOH, that is sodium hydroxide, and incubate it for 30 minutes at 37-degree temperature. And after taking this mixture, shake for a few minutes, then centrifuge it at 3000 rpm for 3 minutes. Discard supernatant fluids, and the remaining deposit should be mixed with 5% HCl drop by drop until this indicator give you some red color. So after neutralized deposits, you have to make a spear from that deposits, and this whole method is known as Petrov's method. So this is how unnecessary material get destroyed and you get a proper diagnostic material, and on that material you will go for Zn stain or immunofluorescence or whatever test you are going to perform. So this is how sometimes apart from this Zn stain you go for some media culture also, that is on algae media, dosetic media. You use this preparation on this media also, and sometimes you go for genopic inoculation, that is animal experimental study. So this is how concentration method is useful when there is a low quantity of sputum or it is mixed with some contaminated material. And last but not least, that is the exfoliative cytology of the sputum. A very important indication is lung cancer. In the earlier stage, exfoliative means epithelial cells sedate de novo, and you have to capture all these malignant epithelial cells. They are normally sedate. So early diagnosis screening for lung cancer. Sometimes it is useful in pneumonia, tuberculosis, asbestos bodies or fibers in case of asbestosis, and but usually bronchoscopy and biopsies are useful for malignancy rather than sputum cytology. But this is very important tool. Smear are this material are fixed with ether alcohol, that is 95% ether alcohol for at least 50 minutes, and then go for pap stain, that is papinocola stain. Normal lung cells are present in the small sample, in the sputum sample microscopically, but cancer cells, whenever you find, it is the diagnostic. So you can find such kind of abnormal cells. You can see all malignant features like high NC ratio, anisonucleosis variation in the size and shape of the cells, prominent nucleoli, typical 3D ball-like cluster is over here. You will find a high large nuclei of the cells. You can find over here also. There are even seeds. You can find such kind of orangophilia when there is a squamous cell carcinoma of lung. So all kind of malignancy of the lung that can be present on the sputum cytology, and this is how sputum cytology useful for early screening of lung carcinoma. So that's all about sputum examination. Start from physical examination, uh, microscopic, particularly saline preparation, wet preparation, some Zn stain, gram stain like procedure, then some special stains like immunofluorescence, and lastly sputum cytology. So that's all about sputum examination as well as stool examination. So if you find any query, feel free to ask me at any time. Thank you very much.